Okay, I'm going to go ahead and get started. Good morning, everyone. This is Sue Grinnell. And before we dive into this web discussion, I just want to encourage you to put yourselves on mute and also encourage you to use the chat box during the discussion, and then we're going to open it up for dialogue after the presentation. I also wanted to let you know, just kind of give a little bit of context for where we're at, because I think sometimes we might forget about the 7 catchy core elements. And the first one being shared vision and goals. And a lot of you selected that as one of the elements that you wanted to work on. Most recently, I learned from Barb Masters that they've made some changes in the catchy core elements. And instead of referencing as partnerships as one element and leadership and governance as another, they've combined governance, partnerships, and leadership into one element. And they have added resident engagement. So that's fairly new, and I think it's a great addition because I know a lot of you are working on that. The backbone organization, which most of you are all from, and then data analytics and sharing capacity, wellness fund, and sustainability. And so today we're going to hear information about the issue of sustainability and how others have done some financing and funding. And then lastly, the portfolio of interventions. So listed here are the 5 different interventions that you, in partnership with your ACH membership, are working to identify. And so we've held a variety of different financing web discussions starting in January. We heard from Jim Hester on various types of innovations in population health financing. We heard from Allison Rain and Brendan O'Connor about private capital. Then we most recently heard from Robin Hackey on the issue of community investment. Today, we're going to hear from Enrique Martinez Vidal and Susan Kennedy about their lessons learned from the Payment Reform for Population Health initiative. And then on June 27th, we will be providing an overview of community benefit, and each one of you will get a 1-pager that has information from your local area community benefit. And then lastly, moving into the issue of portfolio of interventions. So I really encourage you to take a look at these. Not all of these have I sent out invites, but these are upcoming different web discussions around the issue of portfolio of interventions. So with that, I'm going to turn this over to Enrique and Susan. Both of them are from Academy Health. Enrique is a vice president there, and Susan is a senior manager. And they're going to share their information and lessons learned from this initiative that was funded by Robert Wood Johnson. And they've asked that we hold questions until the end. So I encourage you, if you have questions, to put them in the chat box. And with that, I'm going to turn it over to Enrique and Susan.
Great. Thanks, Sue. Can everybody hear me?
Mm-hmm.
We'll assume so.
Yes.
We unmuted.
I can hear you.
We're
Yes.
sharing the screen, so can you see the slides as well?
Yes.
Okay, great. So thanks for inviting us to do a little talk about what we found under our project. First of all, I'm Enrique Martinez Vidal. I'm a vice president here at Academy Health. I'm here with Susan, a senior manager, and we sort of headed up the work for Robert Wood Johnson Foundation, as Sue mentioned. Maybe just for 30 seconds, for folks who don't know who Academy Health is, we're a nonprofit, nonpartisan national organization located in Washington, D.C. We basically are a professional organization of health services researchers and policymakers, and our mission is to really make sure that there's good evidence and information about how to improve the healthcare system and try to get that information and evidence into the hand of policymakers and practitioners to help them make good decisions. So we try to support both sides of the research development and the research use and link it together. So this project was really a perfect example of trying to do that work as well. So let's click to the next one. So our project we called Payment Reform for Population Health, and it was for Robert Wood Johnson. As you know, they're very interested in the culture of health these days, social determinants of health. How do you improve population health, looking at both clinical and non-clinical services. And they came to us and asked whether we'd be willing to look at how community-wide population health could be improved by a more supportive healthcare payment system. And we chose the words carefully in terms of supporting community-wide population improvement. It wasn't that we thought the healthcare system should pay for all these different things, but we think that there should be some kind of alignment or participation together to achieve those goals. So this is sort of our mission statement, our vision statement. I would say that for the purposes of population health, we came to the conclusion from the Kindig work that the population we really wanted to focus on was a geographically based total community, not a provider's patient panel or a payer's covered lives, which is a lot of times when you talk to health plans or you talk to provider groups, when they say population health, they talk about their own population. So we wanted to be broader than that, and that actually creates quite a tension for the payment system. Payment models are set up to pay for services for individuals. So it's to make that leap to the total community is actually an interesting dilemma. So this is a framework that we developed. It went through many iterations, but basically the top third of it was, okay, here's the healthcare system. Here's money that's available in the healthcare system. Some of it's through alternative payment models and reimbursement systems. And then as we started exploring more, doing key informant interviews and site visits, et cetera, and you saw some of this referenced, and I'm sure you're seeing this in your work already, is that there's money through community benefits. A lot of times that's what's funding some of these community resources or linking to them. And then there's more work going on the actual operations of healthcare systems, hospital systems, through their employment. How do you do local employment or local procurement that can support the communities? There's a lot of work by the Democracy Collaborative that's focused on that. And then the bottom third, the social determinants of health, was what we thought that we wanted to have the funding for, or the investments in. And then we realized, well, it's not that there's direct money that's flowing across these sectors. There's actually a lot of things that are going on in between the sectors. And that's when we came up with a lot of different engagement vehicles, which are sort of the ways that payment can flow through or pay for a variety of things. And then we realized that there's actually something distinct as well, which is kind of this middleware that you need to create in terms of data infrastructure or collaborations themselves, the practice transformation work, or the, paying for a trusted convener. So actually a lot of the work that I've seen that you're working on is actually supporting the construction of a lot of these engagement enablers and engagement vehicles. So I think it's really critical, the work that you're doing to develop sort of that infrastructure. So many of the issues that we came to see under social determinant of health investment was that they fell into these two big buckets. Again, this was sort of more of our frameworks. One was the whole motivating factor of why would the healthcare system want to invest or pay for these things? And there's a variety of reasons, and so different healthcare organizations or systems are driven by different things. So sometimes they're mission driven, a Dignity Health or something like that, Kaiser, that's their mission to do. Sometimes it's an external policy driven. The state tells the Medicaid program or the Medicaid MCOs, they're going to do this. Trying to get into the business case and the ROI and the evidence is actually a really interesting aspect, because then you're trying to make it sort of self-motivating in a financial way. And we heard over the course of time that ROI was actually less important. I mean, you know, for a long time we heard, oh, if it's an ROI for upstream prevention that's more than a year, they aren't going to invest in it. You know, the health plans, health providers, they need to have that return on investment, short-term return on investment. And we know that upstream prevention is actually much longer term, but we actually heard them getting over that and saying, you know, we can actually see 3 to 5 year return on investments. We can build that into our business models, but they still were really interested in what's the evidence? What should we actually invest in? If we're going to take our money, tell us where it's going to work. So the evidence base, it was really a driver of it, which then can actually make the business case. The business case ROI evidence is really linked. And then once you get past the why, then the question was, how do you do it? What's the nuts and bolts? How do you actually create these financial contracts between healthcare systems and the social service sectors or social CBOs or social, you know, sometimes the public health departments. So there's a number of sort of examples of what you have to get around to do that. And this is the nuts and bolts how area is actually where we're trying to go with our sort of 2.0 of this project. So again, we had another framework we eventually came up with after a lot of sort of interviews and some of the projects that we worked on, some of the sub projects that Susan's going to talk about. We came up with this infographic. Everybody needs an infographic. So these are really what we came to call our 4 foundational elements. One is that you need to have a trusted environment where the collaboration is possible. Often that includes a trusted convener, regional health improvement collaboratives. It could be a public health, a local public health agency that's doing it. We know that's happening in Pittsburgh. Sometimes it's a foundation that's doing it. So it can be a variety of different places where that's happening. The shared data was critical foundational piece to it as well. The alignment of the clinical and community resources was another foundational element. And those 3 actually almost felt like they needed to be in place before you could even have the conversation about payment and financing models. We know they're all interconnected and they're iterative, so we kept them linked and they kind of look equal, but really the payment and the financing one is the hardest to get to, in my opinion, after all the work that we've done. So Susan, maybe I'll let you start talking about, not let you, but have you start talking about some of these collaborative projects.
Thank you. So about 6 months into our 18-month project, the first phase of it was really sort of digging deep with subject matter experts, having many interviews. We even conducted we obviously did literature research, but we conducted some site visits both out to Oregon and Washington State. And at that point, we really began to identify potential projects where we could identify barriers even more closely to the ground, and at some point maybe even pursue busting through some of those barriers. And we'll get to that in a second. But I will discuss sort of those collaborative partners and lessons from those projects. So the first project that this was also part of that information gathering stage. We actually worked with Dr. G. McGuire at Northeastern University to conduct some case studies. So first one to identify 4 different communities where we thought she was going to be able to find some health systems that were using payment models to address social determinants of health. We quickly realized that might have been too tight a definition, and that in fact maybe it wasn't through payment models, but that there were other ways in which these communities were utilizing community benefit dollars, ad hoc grant resources, et cetera, but that there was a history of at least exploring those social determinants of health from the clinical setting and beyond. So we would say that where this was successful is not in that we identified where there are payment models being utilized. Clearly that was a barrier, but it was in that information and identifying what were those key contextual factors or environmental surroundings where we could identify healthcare systems that were motivated and influenced enough to even pursue some of these non-clinical interventions. So I'm not going to go through it in detail. There are reports on our website, which we'll give you at the end, and you can learn more about each of those sites and what they were intending to do with those dollars. But essentially, the factors were a commitment to multi-sector collaboration. So where there was a history of healthcare system and CBO, community-based organization, or government funded programs and agencies to collaborate together. Housing, for example, in Burlington is an example of that, where they work together both with the CBOs and the government agencies and healthcare system. Commitment to data acquisition and analysis. Again, we find that the healthcare system may play a larger role there by virtue of the fact that they already have a broad and robust infrastructure. Experience with healthcare delivery transformation. So no surprise, maybe in Oregon, states like Vermont, where they already are well known, Minnesota, for that transformation and approaches, they may be more likely to already have started and spearheaded some of this work. And then lastly, our participation in alternative funding and financing efforts. So while it might not be utilizing and looking beyond that clinical wall yet, the fact that they are already starting to consider alternative payment models and financing efforts within the clinical wall, then they may be more likely to step over or through that wall. So where she was, I think Dr. McGuire was extremely informative in our project in identifying those key elements and also noting that they are extremely important. All right, so the next project is the Network for Regional Health Improvement. Many of you may know NHRI. We actually worked with them in 2 different projects on our during our whole 18-month cycle. We first had a convening with 5 of their regional health improvement collaboratives, and we actually asked them, we invited people to apply. And we had criteria by which they needed to demonstrate they were ready for the challenge of exploring where healthcare systems and collaborations could work together, RICs, as they call these regional health improvement collaboratives, to pursue sort of these, sustainable projects that are bringing together the community-based organization and the clinical setting. What came out of that was that we had some interesting findings from that. We learned that we selected these RICs based on what we thought was a demonstrated ability to pursue them, so that they had more of a robust collaboration, that they may be more informed on the payment sector area. What we learned is no, in fact, that they were not very informed at all, that in fact that was lacking. But again, in this in-person meeting, we learned that there are definitive topic areas for further exploration, and that really informed our infographic that you saw at the beginning of this presentation. So we identified that data and population metrics are very important, that we need to consider where there is multi-sector care delivery and opportunity for that. So where they're already spearheading care delivery transformation, and how better to look at those collaborations that right now might be simply grant funded. Also wanted to understand and underscore that it's important to align across the sector. So realizing that there is an importance of a trusted convener. It might not have to be a neutral convener. We had that discussion depending on the setting again, but a trusted convener to explore not only the governance structure between those relationships between the community-based organizations and the healthcare system, and ensure trust. And then payment and financing. Again, that's clearly important. It's the impetus of our project. And at some point it has to be addressed because we're looking to find sustainable actions in payment and financing to fund these projects over time. So they're no longer just ad hoc projects. We then decided that we would continue to work with NHRI and these 5 RICs to provide ongoing TA. We identified that there was clearly technical assistance needed, and we worked, or I should say that NHRI worked with them closely. We had affinity groups focused on those 4 foundational elements, and there are 2 reports to that. One is just an update on what those 5 communities have found. I wouldn't say they moved that much ahead. I would say what might be of interest to our audience today is our second report there, how regional collaboratives can advance funding and financing to improve population health. I think the findings in that can be most useful and helpful, and it simply details, again, sort of underscores a value to how regional collaboratives can sort of also sell themselves and serve in how they can serve in that critical role in spearheading these funding and financing models. So the last one I'm going to talk about, we had 5 total, but the last partnership I want to talk about is the Nemours Children's Health System, and that actually we're just unveiling and promoting the amount. We have about 6 or 7 reports, 6 reports, 1 executive summary report, so 7 total, that gives an overview of how Medicaid programs and policies can be best leveraged in this space to support non-clinical projects that in fact the healthcare system can spearhead and address social determinants of health. So Nemours identified 3 states. This was at the beginning. We didn't prescribe anything. They identified Maryland, Oregon, and Washington, where they thought there were environments and Medicaid authorities where they could largely look to see how best to promote and provide preventative services in community settings upstream, invest in upstream prevention. Each state was relatively, or actually vastly different in their approaches. And I won't go into detail here, but I really encourage you to go to our website, download, again, those reports. I will say this though, across the board, there were some fundamental learnings. Challenges to investing in social determinants. Clearly there is making the case, business case to payers and MCOs for investing in upstream prevention. Understanding, and this one's difficult. It's not that easy to understand what Medicaid can and cannot pay for. States, health plans, and providers often, we should recognize that they often feel like they're breaking new ground, but more recently, there is actually experiences already to refer to. And so we encourage people to explore what Medicaid programs across the country are already looking to do, and MCOs rather. There are a few MCOs out there already breaking ground. Medicaid cannot adequately address and invest in these on its own, so we understand that there is a value again in these partnerships with other agencies and CBOs, regional health improvement collaborations and such. So the other thing to recognize in all this are sort of that there are many opportunities that can overcome these challenges. And no surprise, having the right people at the table. So identifying that leadership is really important. Allowing flexibility on how to accomplish those goals. So maybe not being so prescriptive at times. Again, every Medicaid agency and program is different. So recognizing that and understanding how Medicaid may be different in your own state. California, we know, has quite a bit of flexibility. Identify and build on proven approaches to upstream prevention investments. So again, goes back to what I said before, which is you probably aren't the first one breaking ground. There are examples out there. There are examples in these briefs. So please, again, go to our website and you'll learn from those 3 states. Look for ripe opportunities for cross-sector alignment among specific populations. So it might be chronic conditions in the adult population, but it also may be children. So again, look for, again, specific to your community, what those populations may be that you can leverage. Employ strategies that link traditional clinical care with community-based prevention initiatives as a portfolio of investments. So much like this wellness fund, look for, again, opportunities where there already can blend together these fundings. Focus interventions on the family as a unit of partnership. Again, there are places where you might see that there is an impetus or value in treating an individual, but in fact, if you bring in additional funding, you can actually treat a whole, and you might be able to find additional funding as well to do that. So engage CMS as a partner rather than viewing them only as a payer. This also goes up above to understanding what those leverage points are and also what those opportunities are. So CMS has a role here as well, and has tried to, I know in the last year or so, been able to better advise on what the opportunities for investments, upstream investments are through Medicaid, but recognize them as a partner. Think broadly about ways to use payment reform rather than addressing a specific issue. So again, being more flexible and thinking outside the box, and harness that flexibility under current federal Medicaid regulations, which again, have provided a little bit more guidance in the last year. CMS has provided more guidance, and there's certainly more flexibility. So we'll go to our fourth partner that we worked with.
So thanks, Susan. You can see that a lot of these issues were both the why as well as that how. So especially with the Nemours one, we really started moving into the nuts and bolts of how do you identify the Medicaid regulations that can actually help support those things. And one of our issue briefs, like, literally breaks it down to the regulation, the number of the regulation that you can use to do these sorts of things. So we as we moved, so one of the other things that came out of the NHRI project with our meeting in Austin is that one of the folks who came from the Cincinnati team was a large social service organization, and they were really interested in taking on risk from one of their Medicaid MCOs. They were interested in contracting for the high cost population they were seeing. They were a behavioral health organization that did housing as well. And so they were willing to take on, they had done a data analysis, financial analysis, and seen that 10 of their members were responsible for $10 million worth of costs. I mean, it was some crazy number for a really small number of people. And they said to the MCO, we'll take that risk on for $5 million. You give us $5 million, we'll take 100% risk for those 10 people. And the MCO said, to write a contract that small, it's not even worth our time. It's not worth our administrative time. So we said, okay. So we started working with them through Green and Healthy Homes Initiative, who we had been talking with for a variety of reasons. And they said, well, we could try and find that sweet spot where there's enough risk being shifted to the Talbert House, which was the social service organization, that it makes it, that they feel comfortable holding that risk, but it's also worthwhile for the MCO to shift that risk and enter that, do all the administrative effort to enter that contract. So we worked with them, did a lot of the project planning, the data analysis, the financial analysis. We were pretty far down the road, and then, sad to say, it kind of fell apart. And basically it fell apart on the side of the MCO. And what we found there was that the interests were not aligned internally for the MCO. So even though the behavioral health folks were really interested in doing this, the data people were on board, then the lawyers started getting involved, and then the CFO, and then the community benefits people, and it was sort of like, they just couldn't all come to agreement on it. That was sort of the internal factors of why it didn't work. And then externally at the same time in Ohio, they were carving all the behavioral health services back into the main MCOs. So that just became overwhelming in terms of what the MCOs were focused on. So I would say there were internal and external factors on why it didn't work. But we're publishing shortly an issue brief that really tries to get into the nuts and bolts of how do you think about these contractual agreements and arrangements, and what do you need to do to set the stage for doing that. And there's some lessons learned for that. So building on that, we really understood, I'm gonna go to the next one.
Oh, sorry.
You did. We really wanted to start thinking about, okay, what are the incentives that are in the healthcare system for making these investments or making these payments? And we started trying to pull apart how the money flows through the system. So this first one noted here, making good health, good business, really tries to pull apart how the money flows from purchasers to health plans to providers. And the providers can be both clinical providers and non-clinical social service providers. So we track that through the for the employer market, the individual market, and the public government market. So it's kind of a matrix of tracking the money through there. But what that allows you to actually see is why do health plans make the investments that they do? And they basically they're never incentivized from the employers to try to show good outcomes. They're selling their services on, here's my network, here's my benefits, and here's my price. And there's nothing that says, here are my outcomes for my population. There's no population level outcomes that they're trying to sell on, because the purchasers aren't asking for it either. So anyways, we tracked that all through and then tried to understand how can you start shifting those sort of pressure points and those incentives to get the business models to change themselves. Because, I mean, you can go so far with, the government pushing down and trying to make things happen. And that's a powerful policy lever, but you also want to make it internally. You want to that's why we're calling it make good health, good business. We want the businesses to see how they can change their business models and improve health, and they're actually going to come out as winners. So building on that then is the second one, which is like, okay, now if you have a value-based purchasing model in place and it's pushing you to change those incentives and have those incentives changed and have your business model, here are the things that you actually need to do as a healthcare entity. Here's how you can be a winner in that new model. So we outline all the sort of aspects of, and it's very business, business administration language in it, actually, about how do you change, the way you market yourself, or how do you change your internal inventory structures and all kinds of stuff like that. So it's actually really detailed into the nuts and bolts aspect of these payment models. And those are forthcoming. They're pretty massive. So we've been trying to go through them with a fine-tooth comb, but hopefully they're going to be ready in a couple weeks. And then the last one, again, we got into really some of the nuts and bolts. We did a small project with Discern Health. They're a small consulting group. They do a lot of consulting with Maryland and their global budget, hospital budgets. So they're very knowledgeable about sort of holding risk and again, these financial arrangements. So their paper is really predicated on the idea that healthcare providers and community benefit organizations are at least partially dependent on each other for the health outcomes they achieve. If you're starting to have these health outcomes that are starting to look outside the four clinical walls, then if you can start linking the financial revenue that has been separate and start linking to have financial outcomes linked, then not only do you have sort of health outcomes linked, but then you have financial outcomes linked. And in order to do that, you have to start linking the risk together. And so there's two different models that they frame out in the paper: a parallel risk and hierarchical risk. It gets pretty technical, so I won't get into that. But it really gets into how to do that across the healthcare system and the CBOs, the social service organizations. And then you have to have common measure sets as well. So if you're going to, if both sectors are going to be held to the same financial outcomes, health outcomes, then you have to be able to measure across the systems as well, across the sectors. So we'll quickly go to some challenges and lessons, because I think we want to have some time for Q&A. So.
Yeah.
And everybody going to have the slides too. So, but go ahead.
So thank you. So I'll go through this relatively quickly to get to the piece I think is more important. But to address those lessons learned and back to the foundational elements, those 4 elements, I'll talk about 3 and then refer to Enrique on the payment component. But around trusted environment and convener, I'm guessing this is probably not going to be so much of a surprise, but the value is in underscoring the findings that, it's important to build trust in each other and the convener, that there is this partnership, that there is also sort of a equity, Recognize that all partners have diverse viewpoints, but they also are of equal importance. Try to align around the common interests and goals, certainly around the population that you may be focused on, and maybe measuring, what particularly about that population is of interest to address. Find and foster a community voice. So that's very important. We found in some of the RICs that if they had a particular community advocate, that might be very important to engage, especially in bringing in other key community participants. Exhibit adaptive leadership qualities, again, sort of being flexible to all the different parties. That's very important. Demonstrate effective communication practices. You don't want to underscore, you do want to underscore that this is very important, especially when it comes to how the different partners are communicating to their own staff and colleagues. Utilize community organizing principles. Again, going back to making sure that the governance is sound and making sure that everyone is heard, and that there is sort of equity embedded in that approach. Also, understand that there is a difference between who is the convener and what the convener does. So separate that form from the function is very important in developing this sort of trusted environment. Data and population, I would say here, to ensure that we are moving forward here, just ask yourself, why is data important? There are 3 elements that data brings to this. Of course, analysis, interventions helps you identify what you want to intervene on, and also measuring the outcomes to your approach, to your project approach. So first, the analysis is going to understand who those populations are, where they are, what those key needs are that you wish to address. The interventions themselves are the data is going to help guide that, provide targeted goals, and better inform your intervention. And around the outcomes, you obviously want to track those interventions that are being implemented, and especially around, good example would be around care coordination. And you also want to use it for your measurement and accountability, whether that be for ROI purposes or otherwise. So I won't, again, go through all the bullets, but they're there for you. And then last, I'm the one changing the slide. The last one component that I will focus on is multi-sector care delivery. And again, that is a critical component. I want to say that all of these, there aren't one that needs to be addressed before the other. We've said that from the beginning. These can all be addressed in the same time. Is remember to start small. Maybe identify something that is really practical. Don't get overwhelmed by the idea, when it's population health, you want to think about, the biggest and boldest idea, but perhaps when it comes to data collecting and, again, sort of proof of concept, it's okay to start small. Continue that engagement, again, builds that trusted relationship, brings in leadership, involves the whole team, and ensures commitment, because you need to continue to massage that relationship as best you can to ensure long-standing commitment. You hear that often, that there might be fatigue, people drop off. You have to make sure that there is a continued engagement. Credible data collection analysis is very important. So going back to that other foundational element, there's a lot of overlap here to, in fact, provide that proof of concept for your intervention. Social determinant of health assessments are critical to understand those individual needs and link back to the community services. We hear that often, that there are a variety of assessments and different ones that address the same. So ACEs comes to mind at this moment in time, but there are other assessments that are very important to utilize, and there are many out there to think about in better identifying how you want to address those needs. Involve local community partners in key decision making. Seems obvious, but you may want to be a little bit broader in who you bring to that table. Example would be, I'm just going to give this example, is one of the RICs that we had was from Hawaii. Hilo, Hawaii is a pretty small community, pretty tight knit, and their community advocate and voice was a grocery store owner, and he was very well known in the community. and very well engaged, both with consumers and those sort of in the political decision making, even around, say, the health system and expansion of that health system. And so by bringing him in, there was a lot of built-in trust that he brought with him. So that was interesting to think of. And engage all payers so that you can help shift that care coordination to be seen as a less a utility for the total community. So it allows you to make sure that no one's taking a free ride there, that everybody is participating and sharing that cost and also the value. So I'm gonna, with that, I will.
Yep. So thanks, Susan. We're going to wrap this up pretty quickly. So the more lessons from the payment and financing. One of the things we heard was really to use the existing payment models as a jumping off point. If you try and like layer on yet another payment model to what the community is already working on, it's like it's just like there's payment reform, you know, delivery system transformation fatigue going on. It's like if you can jump on something that's already happening and sort of get everybody sort of aligned on that, that really helps. We heard it called increase the signal strength and reduce noise sort of around the edge. I thought that was an interesting way to think about that. Leveraging the other funding and financing sources. I think you all are recognizing that. You have your wellness fund that's sort of a way to braid and blend. I mean, not only is there the money across that top of that framework with the community benefit money, and I know you're going to talk about that next time, and there's the reimbursement dollars, and there's sort of other money. Sometimes it's grant funding, you know, a variety of sources. And that's just in the healthcare system. There's also money from the other sectors that you can start blending in to reach these community goals. So it's really important to try and sort of align those all together. And with Medicaid, there are some new opportunities that seem to be out there, and our Nemours work really tried to pull that apart. The evidence is really critical. The positive ROI is out there. I don't know if you folks know Siren. I'm sure Sue knows them. The folks at UCSF, they are collecting a lot of great information. One of our other reports from the Washington state work that we did with Nemours really gets into sort of the business case, looking at the ROI and the evidence that's out there for making these investments. It's really valuable to have that sort of in your back pocket as well, to get that business case. And then the intervention savings. You know, if there's a way to recapture that, this is probably one of the hardest things, but, you know, to try and create that cycle, a positive cycle of reinvestment, you know, finding the savings and then reinvesting it. But you really kind of have to have a vehicle to do that. Otherwise, you know, you get that wrong pocket issue, and, you know, whoever's making the investment, they either don't benefit from the savings, or if they benefit, they just take it and pocket it as profit or reduced premium or whatever. So there's always ways, if you can figure out ways to sort of recapture those savings, that's really valuable. So some of the broader lessons that we learned is there's and we already talked about most of this with some of those case studies actually, is that, you know, the sites that have had prior investments really are well placed to do this work. And the transferring healthcare premium resources, I have a mechanism, again, that's sort of back to recapturing the savings. Having a sole or dominant healthcare plan was really, it really was able to move the needle by having that. I mean, there's sort of pros and cons to that, of course, but really being accountable for total cost of care by being a sole or dominant healthcare plan or provider in the market allows them the flexibility to sort of focus on upstream investments. There are downsides to having that if they can control the cost of either reimbursement or premiums. And where care delivery improvements are presently underway, we know that also helps as another enabling factor. And understanding that success begets success. Really the pros of that are, their proof of concept, the trust development. It really can lead to a broader application of the strategy. These experiments with Medicaid, there's a number of states that are trying to finance community health workers out there that are really working. The pathway strategies, I know you're going to look at the Pathways Hub as sort of this connecting, between the sectors. It's really critical. We saw that, and we helped actually one of the CCOs in Oregon really try to shift their grant funding for their Pathways Hub to actually a reimbursement model. So that's an interesting case study there. The cons are once the healthcare system who's been doing this is investing in it and it's successful, there is a tendency to want to try to just pull it in-house. Instead of keeping that subcontracting out into the community with the community benefit organization or whatever, it's like, oh, well, we can do this ourselves. And then it starts medicalizing the solutions. And that's not something I think we want to encourage. So it's sort of a two-edged sword about understanding the success of these models or these interventions. Again, sort of the final lessons, alternative payment models, they rarely directly reimburse for non-clinical social determinants of health related support services. They're not made to do that. They do sometimes, the closer they are to certain clinical aspects, it's easier for them to do. If they want to focus on healthy behaviors, that's easy for them. That's easier for them to do through a reimbursement model. If they're going to pay for playgrounds, that's not going to flow through an alternative payment model. That's going to need to be a grant or some sort of braided funding. The other financing sources, we've already talked about that. You really need to blend that all together. Those are the three funding streams we identified in the healthcare system. The why, the motivation is really just as important as to understand as the how. So here's a few questions that we're still struggling with a little bit. In our last slide, which we'll let you look at it later, but our 2.0 goals are really to get into that granular nuts and bolts of how do you create these contractual financial relationships between the healthcare system, plans and providers, and the community benefit organizations. So when we start thinking about who's in best situated to do that, you have to sort of do a needs analysis on both the healthcare side as well as the CBO side. And the question is, when you look at those foundational elements for the community and all the players, is there a certain level of that sort of those foundational elements that have to be in place for them to be able to get to that conversation about payment? If they're just starting out with the data work, can they really enter into financial relationships? It's uncertain, like how far advanced you have to be in those other foundational elements before you can really make that leap to having those financial arrangement conversations. Again, the second bullet point is what I was just mentioning. Are there some that are more amenable to alternative payment models than sort of other financing sources? What are the contextual and technical factors? We know that every community is a little bit different, depending on what their insurance landscape looks like, what their Medicaid landscape looks like, what their provider landscape looks like, what their community landscape looks like. So it's really critical to understand. And that's one of our 2.0 lessons as well. It's like, how do we pull apart the sort of where it's successful, what makes it successful, both in terms of technical factors, but the contextual factors. And then again, what's the type or the strength of the evidence or ROI that you really need to have in order to get the partners to invest in this? And we've seen that it's shifting a little bit, that the ROI doesn't have to be quite as strong as it used to be. Those sorts of things. So that's another interesting question. And this is another question that we continue to think about in terms of the regional collaboratives. What's their role in addressing this challenge? We think that having that trusted environment and those trusted conveners is a pretty critical foundational element to doing that. Again, separating form from function, as Susan mentioned, is critical, but we think it's a really important question to identify and how you connect those the sectors together. So I'll end there. The 2.0 slide is there. Once you click on to, there's just a little description of it. And then here's our information and our link to all that information that we presented, but all the resources that are there. So sorry we took so long.
No, it's very good. So, and then just for everyone, once we're finished, then I will post the slides and then post some of the resources on our website, as well as the recording. So thank you. So before, you know, I was just kind of jotting down different questions that I thought might be helpful, but I wanted to open it up to the group and see if you had any questions, comments, you know, anything that you'd like to ask. Now, don't all do it at once.
I know that was a lot of information we threw at you.
Yeah, but it's good. Well, maybe all, you know, while maybe people are thinking, I was struck by the infographic and the 4 things, but the fact that you said the alignment has to happen before financing. And I'm just kind of wondering, because it seems like in some ways, some people want to know what they're going to invest in, and that kind of goes into those interventions. And so I don't know if you have any comments. And then related to that, I was also wondering about the metrics. If you found that the communities were coming up with their own metrics, or if they identified a metric set somewhere that seemed to work, because it's also related. So, you know, while they're separate, so those were kind of 2 separate but related just questions that I had, or comments, or anything if you want to kind of share perspective on that.
Yeah, the question of sort of do these other 3 pieces come before the payment? Now, that's why I didn't want to pull it apart completely, because I do think that they are iterative. But I mean, this was our lesson from our Austin meeting, was we thought the target of the conversation was going to be the payment and financing models, and they just couldn't get there. I mean, we had a session on it. But when it came down to like some one-on-one meetings that we had, everybody wanted to talk about the data. And everybody wanted to talk about how do we do cross-sector alignment or collaborations. I mean, they were all pretty good with the trusted environment, because after all, it was NHRI and the RICs, so they were all pretty strong with that part. But they could not get to that conversation about payment. And actually, it was a 2-part conversation, because part of the payment and financing discussion was not only payment for the interventions. There were sort of 3 levels, I should say. One was paying for the interventions and the, you know, those sorts of things, and that's what we were thinking about in terms of alternative payment models. But they were very interested in how do you pay for the actual collaborative, and you know, how do you support the RICs and, you know, those sort of to be sustainable entities, which is another critical aspect. And then how do you pay for that sort of infrastructure? How do you pay for that data, you know, the shared data, and how do you pay for those collaborations? So the convening, or even just having meetings, I mean, they cost money. So yeah. So you know, it was a conversation that is all interrelated, but we tried to pull it apart to some degree, and the APM, alternative payment model, was really the hardest part to get to. And in terms of the metrics, you know, we haven't dived into that in super detail, I would say.
There was a lot of questions at the in-person meeting.
Yeah.
So the way that the in-person meeting, it was really, actually I thought it was really valuable, is the second day, the RICs broke into their own rooms, and they had these round robins with the advisors that presented on these topics. And so I can't remember for how long, but let's just say it was 25 minutes. They would have the payment person come in and say, okay, let's talk about your project specifically. And they had, you know, variety of stakeholders from that involved with that RIC. And the data component, if I recall, really ran the gamut, but it was, again, really at an inferior level of, okay, what data do I need? How do I even look at it? You know, we had someone come and give a beautiful presentation with very robust analytics. And it was very overwhelming, I think.
The Camden Coalition, you can imagine.
Yeah, and so they were like, but what was great is that when he had a one-on-one with them, he's like, start small, start with Excel.
Yeah, start with a spreadsheet.
Excel, you know, get
start
your
with
data
the data
with your
you
health
have.
system, you know, we're not talking anything major here, you know. But again.
And there is actually a lot of work that came out of another project. It was sort of do you know about the All In? You probably know about All In, which came out of DASH and the Community Health Partnership. So they did a lot of work on the data sharing issues as well as some of the governance issues too. So they have really good resources about that issue. But I don't know that they got into metrics that much. In our Discern paper, there's a piece on metrics in there actually.
Okay.
Yeah.
Interesting.
It's an example, so it's not from somewhere else. So it's just posed as a potential, but it might be of use.
Anyone out there have any questions? Humboldt, I know this is something you guys are interested in, anything that strikes you about anything, validates, or something that you think might be a little bit different that you're hearing?
This is Martin. I think validates is a good word. This was incredibly interesting, and I think in many ways it overlaps with what we think that we need to do. I guess the caution I always have is that every community is different, and there's a lot of detail to understand how it might fit into this community.
Yeah.
No, it's absolutely true that the contextual issues matter, but we do think that there's a number of sort of nice frameworks and guidance that I think apply to most communities.
We are a member of NHRI.
Yep, there you go.
Great.
Yeah, Martin, how you doing? I remember you from when we did our other payment reform work brought in all the AF for Keep folks too.
And we are a member of All In now. So I think they'll be hearing, this group will be hearing about resources that's fairly new related to that. So I think that's another one. One thing that you didn't mention, but I know in our conversations back and forth, you've talked about it. And I'm wondering in closing, you kind of alluded to it, this notion of emergence and being adaptable and, all of that. I don't know if you have any thoughts or any lessons you've learned, because it sounded like for you all, maybe there were some lessons there just around emergent strategy and, in this work.
Yeah, that's an interesting question. So we used what was called an emergent strategy for the project itself. RWJ was interested in that. And basically what that allowed us to do, and I think it was actually reflected in the work itself, not just our project, but it was with the understanding that you really don't know everything to start with. And so our project was actually very fluid and flexible, which kind of drove the budget people at RWJ a little crazy. But, we didn't know who we were going to subcontract with because we didn't know what the barriers were that we were going to identify or who we would want to contract with or what we were even going to want to do. So that's why we started out, as Susan mentioned, with this sort of 6-month process of doing site visits and key informant interviews. We talked to Jim Hester, talked to a lot of folks who you've probably talked to, did those case studies. That was kind of one of the first forays into thinking, again, it was emergent. We thought when we contracted with Jean that she was going to really find those alternative payment models. And when she got out there in the field, they weren't there. So then we had to sort of pivot a little bit. So it was more like the unfolding of this information helped guide us. You know, we dropped off, we explored doing some projects with a couple other people, and then that really didn't feel like that was going to lead us where we wanted to go. So not only did the project sort of have this emergent strategy to it, it felt like all the information we were learning also sort of had this emergent strategy sort of aspect to it, which was really interesting, but it's a little unsettling too when you don't really know where you're going exactly.
Well, yeah, and what I'm hearing, I mean, is like just your piece about Gene is you think there's an answer out there, but, you know, maybe the answer isn't, or there's pieces of it, and, you know,
Right.
it's like you're working to get the answer. And I think with a lot of this ACH work, that is like there isn't maybe the perfect answer out there. And so when you are kind of exploring, creating, it is unsettling. But I think just naming it and knowing that's what you're in is important. So.
Yeah. Absolutely. Well, I'm looking forward to seeing what all your communities are going to be doing and working on. It's exciting.
Yeah. Well, good. Well, thank you so much. This was great. And then, like I said, I will post the information, the recording and the slides, and some of your resources. So thank you.
Great.
Thank you.
Thanks, Sue.
Okay.
Bye, everybody.
Bye, everyone.